স্যার স্যার শুরু করুন। স্যার আপনি পারমিশন দিলে আমরা শুরু করি স্যার।
শুরু করে দাও।
Assalamu alaikum and very good evening to you all. Welcome you all to our weekly tumor board session, fortnightly tumor board session. Today we have two foreign faculties. One is Professor Dr. Annie Catherine Goodman from Harvard Medical School, Boston. Another one is, she is gynae oncologist. Another one is Dr. Bhavana Rai. She is from JIPMER. She is professor in Chandigarh Institute of Cancer Institute. And probably Bhavna has joined. Sir, Bhavna joined for a second. Yeah.
Yes.
First, I apologize to you all that my laptop was crashed, so I didn't make my presentation as the good way. My only the presenter, the Dr. Ruxana and Dr. Farhana Kalam, they will talk on their presentation, but the question and everything what I prepared, it was crashed, and so I will ask the question without any presentation. Yeah. So I request Dr. Ruxana Parveen to present her case. Samir, you please share her slide. Dr. Ruxana Parveen's slide.
Is it okay, ma'am?
Ruxana, please.
Am I audible?
Yes.
Good evening, everybody. Honorable Chairperson, respected teachers, most respected our foreign guest, Professor Goodman from USA and Professor Bhavna Rai from India, my favorite and respected mentor, Professor Shahana Parveen Madam, and all other learned viewers, Assalamu alaikum. I am Dr. Ruxana Parveen, RS Gynae Oncology, NICRS. I am welcoming you all to my presentation in Oncology Club Tumor Board. With permission of our chairperson, I would like to start my presentation. Mrs. X, 55 years, postmenopausal, non-diabetic, normotensive housewife. She married at her 14 years of age. She is mother of 6 children, all are delivered vaginally. Age of her last child is 18 years. She has history of taking OCP for 5 to 6 years. She gave no family history of any cancer. She consulted with a gynecologist with the complaints of postmenopausal bleeding for last 2 months. Pervaginal white is discharged for last 6 months and postcoital bleeding for 1 month. Next. Regarding her complaints, she was advised for pap smear for cytological test. On her pap smear, the report was squamous cell carcinoma according to Bethesda cervical reporting system. And after that, she was advised for colposcopic biopsy for confirmation. And that for this, tissue from biopsy was taken and the report was invasive squamous cell carcinoma grade 2. This is the ultrasonogram images of this patient showing this is the bladder, this is the bladder, this is the vagina, cervix, and this is the body of the uterus. Here we have seen that mild endometrial collection in the uterine cavity, mild collection in the endometrial cavity. This is the view film of this patient showing normal excreting both kidneys. Next, this is the contrast axial CT scan of abdomen of this patient showing here, this is liver. No, here yet not the uterus has seen abdominal lymph node not palpable. In this film, The uterus is visible. This is uterus, and within this small collection, the mild collection is visible. Uterus, small collection is visible. This is bladder, uterus. Mild collection is visible within the endometrial cavity. Next. This is the report of CT scan of abdomen of this patient. Here, uterus is normal in size, shape, in position. Myometrium shows normal texture, and there are small amount of hemorrhage. No ascites, no pelvic collection was detected, and bladder and bowel abnormality was not detected. Next. So, for this, she was diagnosed as a case of vaginal carcinoma and referred to NICRS for further management. Next. At NICRS, the examination findings of the patient were, on general examination, her performance status was good. She was mildly anemic, accessible lymph node was not palpable. Her breast examination finds reveals normal, and her thyroid gland are not enlarged. All other vitals are normal. Regarding her parabdominal examination, it reveals no abnormality detected. On pelvic examination, on pars speculum examination, small endophytic growth in the cervix, and upper part of the vaginal wall was ulcerated. On parvaginal examination, cervix small, nodular, and replaced by growth. Upper half of the anterior vaginal wall and upper 1/3 of the posterior and both lateral vaginal walls were involved by small nodular growth. On her parectal examination, right parametrium up to lateral pelvic wall involved by growth, but left parametrium was free. So, according to her pelvic examination, our diagnosis is cervical carcinoma stage 3B. That's all about my cases. Thank you. Thanks to all.
রূপা কি ঢুকছেন? রূপা আর ইউ হিয়ার?
এই নম্বরটি এখন ব্যস্ত আছে।
Hi there. Sorry, it's this is AK. Thank you for your beautiful presentation. I'm sorry, can you hear me?
Yes.
Okay, great. That was a wonderful presentation. And I'm curious what your plans are for therapy at this point.
No, we want to take some comment from our radiology friend. Yeah. Okay. We are waiting for our radiologist friend for some comment from this imaging.
Would you like to make some comment about the total evaluation of the diagnosis? Okay. Okay, would you like to make some comment about the presentation that from the beginning it was thought
Sure.
about vaginal and
Sure.
then, yeah.
First of all, beautiful workup, very, very nice workup. And my one thought is the definition of vaginal cancer versus cervical cancer, right? It looks like the bulk of the cancer is in the vagina, but you have a small lesion on the cervix, and therefore we call it cervical cancer. We sort of define vaginal cancer as not touching the cervix or not touching the vulva. As a result, we probably underdiagnose vaginal cancer because we put it mostly with either cervical or vulvar. It's an academic point. I think the an interesting thing, it will be interesting to hear from the radiologic colleague, is the issue of the hematometria, right? I mean, how does that alter what you're going to do? Does it alter what you're going to do? Are there any risks from having that fluid or blood or whatever that is in the uterus in terms of your treatment of her. So I think that's your biggest issue, right? I mean, if you didn't have that, this would be a straightforward, sad, unfortunate, advanced cervical cancer case that you would treat with chemoradiation. And that would be the standard of care. But the question is there anything different that you have to do when you see a hematometria? And I'm curious from all the eminent and experienced senior people here, what are your thoughts about that?
Yeah, we have Bhavana, Dr. Bhavana.
Bhavna, would you like to make a comment on that? Because she want to know how do you like to manage this patient with a suspected, I mean, there is maybe a hematometra or pyometra. There is a huge collection in the endometrium. So what is your thought about proceeding with the management of this?
Yes. Okay, good evening. And so basically what we do is that we also do encounter patients who have large diseases who end up having the obstruction and then having pyometra most of the times, occasionally hematometra. So what we do is that we know that, once the disease starts responding, it will automatically drain unless it is causing symptoms to the patient. If it's causing fever or the uterus is so enlarged that it is going to cause an increase in the radiation fields. So as long as it is in the, first we see if it's in the true pelvis, fine, but if it is very large, then we do send the patients for drainage.
Can we see the image of the ultrasound? It is a small amount of collection.
Yes, so for that, we don't, I mean, in this given patient, we will really not be doing much. We will just take this patient straight for radiotherapy. And during the course of treatment, once the disease starts responding, it will start draining on its own. So for these kind of patients, we generally do not do any intervention.
So the main point of discussion here is, if there is any collection, whether it is a pyometra or hematometra, what Bhavna said, that is the common practice that normally the oncology, what AK was trying to understand from us, that even it is tempting to make a drain, clear it, then go for treatment. But normally when we plan to do with a chemoradiotherapy, what Bhavna said, that we don't need to drain it, because it will once we start the treatment, the moment we will start responding, it will be automatically drained. Rather going for a drainage with an intervention, and at this type of situation, normally we don't like intervention. So AK, would you like to ask anything else on there?
Okay, are you there?
Oh yeah, I am here. Sorry. I'm involved in a combined surgery with colorectal surgery, but they are doing their part. So this is perfect timing for me. I'm so happy to be here. I think that really again, these are the things that you struggle with in Bangladesh, in India, and for sure we struggle with it in the United States. The incidence of cervical cancer is actually going up here too, for complicated reasons. And so my one question is, what happened before this diagnosis? And just thinking from a public health point of view, to think about, how can we as a world do better to try and find women with cancers that are earlier, right? I mean, if we think about what is her survival will probably be directly based on her incidence of lymph node metastasis. So for a stage, what are we calling this, a stage 3B? Her incidence of lymph node metastasis is upwards of 70%, right? So your ability to cure her is going to be based on your power at local regional control, assuming there's no distance spread. Again, I'm eager to hear from everybody else on this issue. So that's my one public health issue, is that I think as oncologists, while we're taking care of our patient, we also need to step back and think about the public health issues that are behind this. So that would be my only comment. Yeah. Tell me a little bit more, Kamal sir, from the radiation oncology point of view of how you would plan your brachytherapy for her. If you could teach us, I would be grateful.
So today we have Bhavna to teach
All
us.
right.
But
That's
before that,
all
I
right.
would like to ask that are we happy with the workup that has been done? But this
No,
three
not before. Kamal bhai, we want to take a message from here, from Dr. Bhavna, that sometimes we get these types of patients, or also in carcinoma cervix patients where there is the hematometra, we get this type of patient for drainage. But in cervical cancer, the growth is either is cauliflower or what type of growth. If we want to go for the drainage, then there is variable and excessive amount of bleeding. So what is the final recommendation from Bhavna? If the size of the uterus is within the true pelvis, then there is no need of drainage.
That's
Yes.
true. In
Yeah.
fact, even if it is outside the true pelvis, as long as it is comfortably coming in the standard radiation portals, we
Yeah.
really do not ask for drainage. If the radiation portals have to be increased because of the uterus which is enlarged, then definitely we go in for drainage. Or if the patient is symptomatic, like the patient has fever or those kind of things. Other than that, and this is only when we are treating the patients with maybe the standard conventional 4-field or 2-field radiation. In this case, if there is lower vaginal extension. But if you are doing IMRT, then this becomes problematic, because then you need to give large margins, and you need to do adaptive radiation also in these patients, because as the uterus is going to shrink with radiation, you will have to replan this patient in between. So we do encounter such cases, and I would prefer to treat this patient with a conventional treatment field rather than any fancy radiation modality, any other. And so basically, that is what we do. And like Kamal Bhai said, that again, doing an intervention is something which we really do not want. An unnecessary intervention, it takes more time, we delay the treatment, and the patient has to be started on antibiotics, has to be posted in the OT. So those are the things we really do not want at this point in time in a patient who is already quite advanced.
Thank you. Thank you. We have some, Kamal bhai, we have some question.
Yeah, please.
Samir. Yeah. So there is a dilemma whether it is carcinoma cervix or it is the carcinoma vagina. How can we proceed with these patients? Okay. Okay.
Oh, hi. Sorry. I'm having technical issues here. Can you hear me?
Yes.
Okay, good. So we're talking about this patient. I agree to not do a drainage based on the scan, and also clinically, unless she's having a fever, she's septic, she's toxic, I would go straight for proceeding with treatment. In terms of issues of other workup, I think you've done your workup. For sure, you can always do more workup. You could get a PET CT scan that would tell you a little more information about your nodes, and that might help you decide what your radiation fields are. On the other hand, with a big tumor like that, you're clearly going to be radiating her pelvics and her common iliacs, and most likely her lower para-aortics. But again, a PET CT scan may give you more information if you have the ability, if the patient has the finances. If they do not, I think you've got really a lot of good information. I'm not really sure what the role for a second biopsy would help you with. You sort of have your diagnosis. And I think I would probably proceed with concurrent chemotherapy and radiation therapy. I mean, the thing that's going to be what cures her is your really good central radiation, usually with brachytherapy. It's probably at that time that you need to re-image her to look at that hematometria and sort of see where you are with that. Again, if you have good information from your exam, adding an MRI, if that's helpful for radiation planning, go for it. Yeah, and then like I said, the PET CT scan really, I think, would give you more information about your lymphatic spread, and that may be useful. I mean, for instance, what if you get a PET CT scan and she's got positive mediastinal and supraclavicular nodes, right? If you have that setting, you're basically talking about a palliative situation. In that setting, you might go straight to chemotherapy. We think about going to cisplatin, Taxol, and bevacizumab if you have a disease that's in her above her, diaphragm. So a PET might help you triage to, can you cure her, or are you just palliating her? So those would be my thoughts.
So should we not differentiate it whether it is vaginal carcinoma or carcinoma cervix? Should we not?
Again, I think it's an arbitrary definition based on whether it's touching the cervix or not. I think that your definition that it's a stage 3B cervical is totally fine. I mean, you could call it a vaginal cancer, but ultimately you're going to treat it the same. So it's more important for just your database and your national statistics. But anything, the definition is anything that's touching the cervix, we'd call a cervical cancer. So again, I don't know that additional information in an invasive, local, regionally advanced lower genital tract cancer is important, except for the issue that I talked about, which is, does she have disease you can cure with righteous concurrent chemotherapy, radiation, and brachytherapy? Or does she sadly have a situation where you can only palliate her, and it would change what you do for her in terms of your radical radiation therapy?
Bhavna?
Yes, I would definitely agree with Dr. Goodman in saying that, I think she needs some kind of a systemic workup, because there is a chance that this patient could have metastasis or spread outside the pelvis. However, having said that, she is a locally advanced cancer, and the situation might be a little different or difficult in LMIC, especially where we deal with large number of patients and where there are financial issues. So what we generally do in these patients is that we have started doing a workup of a baseline CT chest, abdomen, and pelvis, if not a PET, because that is more cost effective. And in our center, we have a waiting list of 3 months for a PET. And the PET is much far more expensive than the cost of the entire treatment. So that is the reason that we reserve PET only in situations, in patients who can either afford or where we could expect a curative potential, or where the patients could afford. Other than that, an MRI, yes. Again, if the logistics is not an issue, an MRI will definitely give us more information about the local spread. So you can plan your brachytherapy or that accordingly, and also feels that will give you information about intrauterine spread, about the parametrial extension, because what I gather is that we have clinically staged her to be stage 3B. There's a clinically, we felt that the parameters extend to the lateral pelvic wall, and we know that there could be discrepancies regarding the same. Second biopsy, no, not required. Dual pathology, no. It is what the classical teaching has been, that vaginal cancer, the diagnosis of CA vagina is basically a diagnosis by exclusion. You have to exclude cervical cancer. And if there is evidence of cervical involvement, it is considered as CA vagina. And in this case, and you should have about what we were taught was that there should be a gap of at least the vaginal extension should not be going up to the fornices. There should be a gap of at least 2 centimeters from the cervix to call it as CA vagina. If you have a vaginal extension which is going up to the fornices, again, we say that it is a CA cervix rather than a CA vagina. Dr. Kamal, would you like to add anything on that?
Yeah, Bhavna, I totally agree with you. But what I think that is important, because yes, we know when it is stage 3, the role of PET CT is very high because the nodal yield is around 20% more than classical CT.
Yeah.
But as you said, in our country perspective also, the mostly, the cervical cancer occurs in the poor generation, and in the government center, it is difficult to bear the cost of the treatment. So it is not always possible to offer a costly intervention like PET-CT. Even we know it can give us some better information. So normally what we do also in this type of situation, personally, I would have gone for a CT chest with contrast just to exclude any medicinal notes, what AK was telling. And what I'm really concerned about this patient is that whether there is any nodes beyond pelvis, because whether we need to do that extended field irradiation, that is a important for prophylactic para-aortic irradiation, that is important here. And in one of our study in FNCA protocol, I don't know whether you practice or not, that we have seen that if there is a pelvic node positive in cervical cancer, even there is no para-aortic positive, we do prophylactic irradiation, and it gives, we have published in Red Journal that 73% survival in this group by adding this. So that is a very good thing here. And another point I think you should discuss here for our juniors, that we are making a debate, academic debate, whether it is a vaginal cancer or a cervical cancer. But the bottom line is, even say, for example, it was a vaginal cancer, our treatment would have been almost the same. I mean, in this type of extensive disease, if the vaginal cancer, say, for example, went up and reached to the cervix and all these things, whether there will be classically in any big difference. If it is a very pure vaginal cancer limited to vagina, then only we have a different mode of treatment. But when there is an extensive disease like this, so that is another message I think you should give to the junior, that when it is a different, when we treat vagina as a separate modality, not like cervical cancer, but when we treat, it is almost the same, like cervical cancer and vaginal cancer together, when the mass is like this, so it's extending to the whole bunch of the area.
True. Actually, there are some indirect clinical pointers also where, which are probably not classically mentioned in the textbook, but I think as experiencing Dr. AK and Dr. Kamal and Shana ma'am, maybe you would have also experienced the same. The vaginal cancers typically arise in the lower or the mid third of the vagina. And if it's a locally advanced vaginal cancer, they also have spread to the paravaginal tissues, which is not in this case. So she has a very classical spread of a parametrium, right, on one side, right up to the lateral pelvic wall. The vaginal extension is in the upper half, and it is probably in continuation with the cervix. So these are the indirect pointers which you could also keep in mind before labeling it as clear vagina. And like I said before, the classical teaching has been that vaginal cancers are diagnosed by exclusion. They are not diagnosed upfront. I would welcome some comments from Dr. AK on that.
Sorry, I completely agree. Beautifully said. And the only additional thing in a true vaginal cancer, just looking at retrospective information, is that there is a higher incidence of lung metastases. So the pattern of spread for a true vaginal cancer, and perhaps it's, as you say, just the lymphatic and blood flow to the mid to lower vagina is a little different. And of course, it can also travel to the inguinal region. So that's the other thing. But again, for this patient, she's got a bulky disease in her upper vagina, and you think it's cervical. But if it truly is vaginal, there might be a slightly increased risk of a spread to the chest.
Excuse me.
What I was asking you, say for example, for this patient, let us, AK was asking that as a radiation oncology perspective, what will be your plan of treatment for this patient? I mean, with all EBRT and brachytotal plan, what do you want to do, number one? Number two, I think it is important, even vaginal cancer is very rare, not very common, but we need to tell our juniors that the total field planning and everything is totally different when we see a classical vaginal cancer. We hardly find it, but when we find it, we need, as AK was telling, we need to address the inguinal, which we hardly consider when we are treating a cervical cancer. True. Would you like to make some comment on that?
True. Okay, so what we have in this workup is that we have a CT scan of the abdomen and the pelvic region, and that CT scan clearly says that the aortic region, the para-aortic region, they are all okay. So with that CT scan report, I would take that there are no lymph nodes, there is gross lymph node involvement. And microscopic we cannot rule out, or lymph nodes which are smaller we cannot say, but definitely there is no gross lymphadenopathy on the face of it. So I would take it as a pelvic confined disease, and the disease which is extending to the vagina. So what we have to do is that we will, for the radiation part, we have to ensure, since this is not extending to the lower third of the vagina, inguinal lymph nodes do not need to be included in the radiation portals. We will go ahead with the standard superior portals, that is at the level of the aortic bifurcation. We will again take 1 to 2 centimeters from the lateral pelvic wall, or if you're doing by conformal radiation, go according to the standard guidelines of CTV contouring, CTV nodal and tumor contouring. But for the lower border in this patient, you have to take a 2 centimeters from the vagina or the whole vagina, depending on what your institutional practice is. So in this particular patient, for radiation portals, the only difference is going to be that our inferior borders or the cranial borders are going to extend lower as compared to our standard portals to encompass the microscopic spread in the vagina to include the lower part of the vagina. Now for brachytherapy, again, this patient will need advanced brachytherapy because, and it will also depend upon her response. There is extension to the upper half. So depending on the response, since she is 3B, I mean, I feel if the response is extraordinarily good, then she qualifies for intracavity alone. Otherwise, in all probability, she will require a combined intracavity and an interstitial implant. Had it been CA vagina, localized only to the vagina, you could do an interstitial implant itself. Some centers prefer to do a central tandem in the uterine cavity with a cylinder if there is superficial involvement of the vagina. If there is deep involvement, they prefer to do an interstitial brachytherapy.
We have one question. That's in what patients we will go for the CT test? In stage 2B or stage 2A onwards? Which patients? Every patient, as you know, in our country, every patient cannot do such type of the costly investigations. There is a CT abdomen, again CT test. When will you go for the CT test?
CT chest. Okay.
Yeah.
Dr. Shahana, actually, the good thing that in our institute is, which you could also talk, what we did was that we asked the radiologist to have the same package for a CT chest, abdomen, pelvis as that of abdomen, pelvis. So that way, what we have started doing is that every patient who is a locally advanced cervical cancer, we send for CT chest, abdomen, pelvis. If not, then we go in for CT abdomen and pelvis and an X-ray. So we are not very stringent regarding our imaging or radiological workup. It depends on a lot of issues. If the patient cannot even afford a CT scan, we usually take simple ultrasound abdomen and pelvis and an X-ray chest. So depending on what situation you are in, even the FIGO allows that. FIGO does talk about advanced imaging, but then it is not mandatory. So whatever your logistics allow, basic idea is that you should image the abdomen, the entire abdomen if possible, and the chest in the form of an X-ray chest. That is the minimum that is required. So you could probably...
I would like to comment, Bhavna, that the message is that we prefer advanced imaging, but
Yes.
in resource limited situation, we can consider ultrasonogram and X-ray chest. But nobody should take a message from here that it is fair enough. It is a situation where we are compelled to do this. But in a stage 3B, and a patient like this, I would love to have a CT chest because maybe we may miss something in X-ray chest, because X-ray chest, most of the time we miss many things. So because there is a fair chance of distant metastasis. And as you said, if we didn't have a X-ray CT scan abdomen, we could hardly make a comment about that there was no nodes, because ultrasonogram cannot give us a good information about the nodes. And we know as a radiation oncologist, nodes makes a big issue in our radiation planning.
It's all the difference. Actually, our standard protocol now for all patients is a CT chest, abdomen, pelvis. That's the basic minimum that we do, unless of course there are some other issues. So if you're in a government institute, like I said, we probably ended up in reducing the cost of the CT chest. I mean, the combined CCT, chest, abdomen, pelvis. So that would be the ideal thing, and I fully agree with it. And like we have guidelines also, the NCG guidelines. There also we know that there is a basic minimum, there is an ideal situation. So depending again where and how you are placed, and like you very well said, the basic imaging or the basic workup has to be done.
So Bhavna, would you make a comment, like to comment about the doses that are brachia, how many fraction? I mean, what will be is this 3B? Because there is a debate here about because all patients are treated in almost in the same fashion. So for this particular patient, what will be your recommended dose for EBRT and brachia?
See, for EBRT, the standard dose that we follow is 46 gray in 23 fractions, and that is the dose that has even been recommended by the Embrace now, 45 in 25 or 46 in 23. The reason being that it reduces the toxicity of the bowel if you are giving a smaller dose. And actually, you can consolidate the dose in the brachytherapy. So the total dose, that is the EQD2 or the 2 gray equivalent dose that the patient should receive is 85 gray, which is both combined from external and brachy. So if you're giving 46 gray, the rest of the dose can be given by brachytherapy. In this patient, I don't think that she would, I mean, it will again depend upon her response and the type of tumor that is. And that is, I think, one thing we didn't discuss before. Was this an exophytic tumor or was this an endophytic tumor? Because again, the response varies in these patients. So the dose of brachytherapy that I would like to give in this patient is that I would like to give it either 7 into 4. I mean, I would want to take the EQD2 of to the tumor to 85 gray.
So for the junior colleagues, the comment that Bhavna made is very important. You should notice that she don't want 50 gray, she want 46 or 45 gray, because by discarding this 5 or 4 gray, she's testing goes by brachytherapy, because in brachy, the contribution is more to the tumor, less to the rectum, bowel dose and rectum dose. So the message here is that normally we think of 50 gray is the pelvic standard for 25 fraction 50 gray, but in cervical cancer, where we are combining EBRT with brachytherapy, the Embrace recommendation and most of the center recommendation is we should not go beyond 46 or 45, because we don't need that, because to get the 85 or 90 gray in the point A BD equivalent dose, we can play with the brachytherapy. We can add more fraction of brachy that will not make more toxicity, but this 5 gray may cause a big toxicity on the rectal dose or on the bowel dose. So that is a big issue here. That what she was telling, bowel dose, because this bowel dose can intervene, I mean, make an interruption in your total treatment. If the patient, we need a continuous treatment, uninterrupted treatment. So that is a message that I wanted to give to the colleague through Bhavna, that it is, if we want to increase the dose, we should play with the brachy, not with the EBRT.
Kamalji, can I add something?
Yeah, please.
Yeah, another thing that I think we need to take into account, which is not probably pertinent to this patient, is that if there are lymph nodes, then of course you would need some dose escalation. And like I gather, since most of the patients are being treated with conventional techniques, in those cases, yes, we would probably need to take our external RT doses to at least to 50 gray, maybe 50.8 in 28 fractions or 50. But other than that, for other patients, it's 46 in 23 or 45 in 25.
Yeah.
Unless you are doing IMRT, where again,
for a dose higher, then, but normally to cover the cervix, we don't need the EBRT much. We can play with this ICRT.
Yes.
So what about the giving the brachytherapy after EBRT or at the last part of EBRT? What is your practice and what is your recommendation?
Practice is that we try our best to complete the treatment within 7 to 8 weeks. 7 weeks becomes usually difficult for us, again, because of the limited OT dates that we have. So depending on, most of the patients receive brachytherapy after completion of external RT, but we ensure that it is not later than 8 weeks. So we usually, one way of doing it is, if you have a long waiting list, is that we start, we do the PSC clearances on everything during the course of external radiation. So in that way, you do not waste time sending the patient for a PSC after external radiotherapy. The other thing is that we give the dates on the day the patient is completing the radiation, or maybe in the last week when the patient is coming for a weekly review. So we block the dates upfront. So that is how
How many
we
brachy
do
per
it.
week you do? How many insertion per week you do?
Per week it is single insertion. We do not exceed more than one insertion. Yes, but for dose escalation protocols like 7-4, then we give 2 fractions in one insertion, something similar to what the Vienna group does. So we will give 2 applications 1 week apart, but we will give 2 fractions for a given application, one today and the other the next day after the overnight. Or sometimes occasionally during this lockdown, we have even given 2 fractions on the same day, keeping the interfraction interval to minimum of 6 hours.
Okay. So there is a question, I think, in the chat box from Dr. Altaf. Would you, Dr. Riyad, would you like to make the question? Ask the question.
Thank you, sir. Sir, in this case, as parametrum is involved and pelvic wall is also involved, so should we increase the dose of EBRT with midline shielding? Because as far as we know, brachytherapy cannot cover the whole dose in pelvic wall or parametria. So should we increase the dose in case of EBRT? Should we escalate it with midline shielding?
Bhavna.
Yes. So see, again, you have to assess the patient towards the completion of radiation. Okay. And then you can decide. Like I said, 3B, sometimes what we realized over the years is it's actually the 2B that's more common. 3B is probably an over this thing that we do. Anyways, giving the benefit that it is a true 3B, you have to wait for the response. You see the response. If the disease you feel has responded very well, and it can be covered with the standard brachytherapy protocol, you don't need to give a parametric boost. But if, yes, you rightly said, if there is disease again up to the lateral pelvic wall, and you do not have a provision for interstitial, again, that will not reach, you need to have the tilted needles, you can give a parametric boost. And you can give a parametric boost, 10 gray in 5 fractions. So I don't know what your practice is, what your local practice is, but you could give 10 gray 5 fractions parametric boost after shielding of the midline regions.
Thank you, madam.
Anybody who can comment? Anybody can comment anywhere.
Yeah, there is some question also comment, but before that, I want to add with Bhavna finishing the radiotherapy portion, that what Bhavna said that the end of the EBRT, say for example, what I practice is normally after 15 fraction, I do examination, I try to start the brachytherapy, and normally what I do in between the last part of the EBRT, I complete the brachytherapy. So that is also a practice that can be done, and the message is that it is okay to do at the end, but there is no additional toxicity if we combine the brachytherapy along with the EBRT at the last part of the treatment, so that what we do, we get a shorter treatment time. And another hidden benefit, which we don't know, maybe it's a benefit or not, that the brachytherapy is done during the time of concurrent chemotherapy. There is no data that along with brachytherapy gives the additional benefit, but somebody believes that it may. So my message is that if we can do is judiciously and we take a correct decision, end of the treatment or at the last part of the treatment, once in a week, twice in a week, even twice in a day is not an issue. Issue is how you are planning the treatment, what is the mode of your treatment delivery, and what is the selection of your treatment modality. That is the main message. And very important is, if we have the real stage, we should not undertreat. That means the 0.8 dose, when it is a 2B above, it should be more than 80 gray. We should not underdose, because we know it is a very good responding tumor. If we underdose, then even after the very good treatment, there will be recurrence. So it should be 85 or 85 plus when we are thinking to be above or 3A or 3B. So that was the thing. And now I think in the chat box, there is a question from comment from Jannat.
We have the on another questions. Yes, also it is not under treatment. Also, it should not be over treatment. Sometimes we get the patient, there is this vaginal wall and the rectal wall, it is excessive fibrosis. And so not only the under treatment, also the over treatment.
It is not over treatment.
That is not over treatment. I mean, that's an excellent point that you made, Dr. Kamal. If you are being able to do the brachytherapy from 3rd week onwards, there is nothing like it. I mean, like you said, the overall treatment time has to be respected, because for every lost day, we lose 1% control beyond 7 weeks. So the overall treatment time has to be respected. And I think you are doing a fantastic job if you are starting after 15 fractions. That's great. We find it difficult because of logistics and because of non-availability of ORs, but that's really nice and commendable.
But
Yeah,
Brakitra,
but I'm trying to make a comment about the overtreatment. What I want to say, it is not the result that what they find, sometimes the fibrosis and other thing, it is not necessarily overtreatment. It is maybe not a proper treatment. The lack of, because it is not the dose. Cervix is an area where we can give even 100 grade dose. But sometimes these things happen, we see at the end of the treatment, because not for the over treatment, maybe for the improper treatment. Would you like to make some comment on that?
yes.
Yes, actually, vaginal toxicity has been recognized now, and we are still not very sure. We do not have the dose volume parameters to say that what causes fibrosis, what causes what dose. We are still, there are studies pointing out towards it, but then we cannot call it as over treatment at all. There could be a lot of factors leading to that vaginal toxicity. So as of today, we do not have robust scientific evidence to say that this is form of overtreatment. And yes, like Dr. Kamal said, there are studies coming now after the embrace group. They are identifying points in the vagina which could lead to certain toxicities. But again, but if you remember, the classical teaching of Patterson, there they had clearly said that the vaginal mucosa should not receive more than 40% of the vaginal loading. So it has got to do something with the vaginal loading as well. And also, again, what is coming up is that for vaginal toxicity, the point that you can use is the rectovaginal septum that we have used all our life as the ICRU rectal point. So exceeding dose more than 65 grade to the ICRU rectovaginal point or the ICRU rectal point that we take could lead to more vaginal toxicity. So that is again one point, like Dr. Shahana, in a way we could, but again, this is all evolving still.
Thank you. Thank you. Now we'll go for the second case, but before
There is a
that,
comment. No,
Jannatul,
no, no. There is a comment from Jannatul. She wants to make a question and comment.
Jannatul, she wants to give some comment.
Okay, thank you so much for giving me the chance. I am Dr. Jannatul Firdaus, working at BSMMU. Actually, I want to comment on two things, and I have two questions, one to AK and one to Dr. Bhavana. My comment is that traditionally we drain hematometra before radiotherapy, and it is very difficult to convince our radiation oncologist not to drain. Even today, one patient referred to me to drain before radiotherapy from the Department of Radiotherapy. So I don't know how we could convince our colleague, radiotherapy colleague. And another thing, as Dr. Shahana has mentioned, that when we will suggest to do CT scan in case of CS cervix, actually, when the vagina is involved in CS cervix, that is from stage 2A to stage 4, better to do a CT chest if the patient can afford. And these are my two comments and my question to AK, and I think AK is not with us. So I'd like to ask to Dr. Bhavana both the questions. This is very basic questions. Do you suggest prophylactic ureteric stenting in this case, that is in stage 3B, before giving radiotherapy? And another question is, do you suggest to do cystoscopy in this case as upper half of the anterior vaginal wall is involved? Thank you.
As far as prophylactic ureteric stenting is concerned, we are not doing prophylactic ureteric stenting unless the patient has moderate hydronephrosis. Then also we seek a urologist opinion, but generally not. The other thing regarding cystoscopy, yes, this was a practice which was being routinely followed for patients with vaginal extension at our institute. But again, over the few years, this kind of faded away. We are more, again, because it was mainly because of logistics. But since we have MRI as a good imaging, if the patients can afford an MR, we get an MR, and that gives you a very wonderful picture or a clear picture of the bladder involvement and the extent of bladder involvement. So we send the patients for cystoscopy only, if there is very large vaginal extension, maybe till the lower third, or it's just going up to the introitus. Other than that, if most of the patients come with an MR from outside, so that gives us a very good picture about the bladder or the rectal invasion.
Okay, thank
What
you.
is the local practice there at?
Yeah. So from this case, what is our learning? That we must have to clinically examine the patient carefully, whether it is carcinoma cervix or it is carcinoma vagina. We must carefully examine it. We usually learn our doctors and usually teach them that if there is any gap between the cervical growth and the vaginal growth, there is continuation of the cervical growth up to the vagina, then usually we clinically we tell it the cervical carcinoma. And if there is cervix is clinically it is smooth, no growth, only the upper third vagina, then the growth, then it is we tell it is the carcinoma vagina. And in carcinoma vagina, we must exclude there is must involvement, usually involvement of the inguinal lymph node, usually. So learning from this cases, we must have to evaluate the patient carefully. We must examine the clinical examination, that is biennial, bimanual, and the speculum examination. Thank you. Is there anybody who can comment? Otherwise, we'll go for our second case.
Shana, I like to comment.
Yes, thank you, Appa.
Thank you, most welcome. I appreciate Bhavana Rai, her clear explanation of management of hematometra. Since many times radiologists requested us to do drain pyometra, but it is really sometimes it is dangerous because chances of perforation, uterine perforation, or chances of bladder perforation also there. I know some cases in our past, there are they random used to drain pyometra or hematometra. So it is a clear message, if the pyometra or hematometra is small, we could keep it in situ and we will continue definitive management. So, and on the other point, for our students, you have to know, identify the lesion, either it is in the cervix or in the vagina. These are the total different entities, and place also different. So don't miss the lesion if it is in the cervix, because cervix sometimes remain flaccid and the lesion remain endophytic, different even inside. There may be cavitation or other, you may not, you could not see the lesion without under anesthesia. So if you have any confusion, just do the case under anesthesia, examination under anesthesia. It will sort out most of our cases, either it is vaginal or cervical. Most of the cervical cancer extended through parametrium, and most of the vaginal extension, most of the time mainly paravaginal tissue, extension to the paravaginal tissue. So there are typically different situation usually. It is usually. So this is a very good interactive session. I enjoyed very much, and I welcome you all for next session. Thank you, Shana.
Thank you, Appa. Thank you very much. Next, we'll
Hannah,
do for our
I want to make one comment about the Jonaki and Rokia's comment, that we oncologists are scared of fluid. Say when it is effusion in lung, we don't give radiation. So the problem here is the fluid. So many of our colleagues, maybe what Jannatul said and Rokia said, some of our colleagues are sometimes with that. So when it is ascites, we don't give radiation. When it is a effusion, we don't give radiation. But this is a totally different scenario. So the message also for our radiation junior colleagues that this is a unique situation where this fluid is not a contraindication, because uterus is not our main target. Target is the cervix where there is no fluid. Uterus is having some fluid, whether it's a pyometra or a hematometra, and we know the moment we give radiation, within a day, within a week, it will start draining, and one day it will become empty. So the colleagues that who are sending patients to you people and putting you in danger is probably they are scared of the fluid, and hopefully in future we will not be scared of fluid, and we will be treating with hematometra, pyometra without draining and bothering you. Thank you. Shana, next case.
yeah, we'll go for our next case. Our next presenter is Dr. Farhana Kalam. Samir, please share her slides.
Am I audible?
Yes, please.
Yeah.
Honorable Chairperson, distinguished professor from home and abroad. Assalamu alaikum and good evening. I'm Dr. Farhana Kalam. I'm going to present my case. Next, please. Mrs. X, 44 years, para 2, living 1, service holder, was attended to a private hospital on 29 September with the complaints of postcoital bleeding for 1 year and mild lower abdominal pain for same duration. Her menstrual cycle was regular with average flow and duration, and last menstrual period was on 28 September. Her menarche at the age of 13 years. Personal history: age of marriage at 25 years and age of first childbirth at 28 years. Contraceptive history revealed she used OCP and barrier method for few years. Next, please. Examination finding: on 29 September, she was anemic. Per abdominal examination reveals nothing abnormality. Per speculum examination, ulcerative growth in posterior lip of cervix. Per vaginal examination, right fornix free, left fornix thick, short and tender. Cervix hard in consistency. Rectovaginal examination revealed right parametrium free, left parametrium thick. And then then clinical diagnosis was CS cervix stage 2B. Query. Then examination under anesthesia with cervical biopsy was planned for her. Examination under anesthesia with cervical biopsy and clinical staging revealed there was a growth of about 1 centimeter in posterior lip of cervix, friable and bleached on touch, left fornix slightly shallow, right fornix clear, cervix as a whole broad, but no other palpable mass in it. Per rectal examination, no deposit in pouch of Douglas or fornix. Multiple biopsy was taken from cervix and endocervical curettage was done. Histopathology report cervical tissue adenocarcinoma of the cervix. Then the final diagnosis was CS cervix stage 2B. She was referred to radiation oncologist for chemoradiation, but the patient reported to NICRH for further evaluation on 13th October 2020. At NICRH, we examined her. She was anxious but cooperative, performance status 0. She was mildly anemic, non-icterus, no accessible lymph node was palpable. Per speculum, ulcerative growth present. Per vaginal examination, left fornix shallow. Per rectal examination, left parametrium thick. Our clinical diagnosis was CS cervix stage 2B on query. Then we had done diagnostic workup and all investigation for her GA fitness were normal. And these are her other investigation. This is her ultrasonogram report, which shows cervix is broad. This is our MRI of pelvis with contrast. This is a focus picture of uterus. This is axial view. And the final MRI of pelvis report shows bulky uterus with intramural fibroid and broadened cervix.
The next, Samir, next one. What we did in this position, what we did for these patients, as it was a carcinoma cervix, and his histopathology report was the adenocarcinoma, and there was the small ulcerative growth just anterior lip of the cervix. It is around 1 centimeter growth in the anterior lip of the cervix, but it was in adenocarcinoma, and it was query cervical carcinoma stage 2B. It is whether it is 2A or 2B. As because it was adenocarcinoma, so we did surgery for these patients. Next, what we did? Next slide.
Our treatment plan was surgery for that patient. The surgery was done, that is radical hysterectomy with bilateral pelvic lymph node dissection was done. And here her histopathology report, which shows, next slide please. The report is hazy. I'm making the comment, adenocarcinoma in situ. Next please. This is also hazy report. Right-sided pelvic lymph node shows non-reactive change. Next, please. Left-sided pelvic lymph node, non-reactive changes. And this is in summary of that report. Pathological staging, TIS, the tumor is limited within a small focus of endocervix without invasion into subepithelium. NX, nodal involvement is not seen. MX, distant metastasis cannot be assessed. So final diagnosis from histopathology, this is a case of adenocarcinoma in situ, small focus. Next, please. Thank you very much for patience hearing.
We did surgery for this patient. Anybody's any comment from any corner? It was adenocarcinoma stage 2B. Is there any comment?
What is the post-operative finding?
This was the post-operative findings, sir. Adenocarcinoma in situ.
I mean, emergency was clear. You did hysterectomy or
Everything. There is no parameter involvement, nothing.
good surgery.
I wanted to know that clinically you saw a growth at the cervix?
Clinically, it was just 1 centimeter growth, 1 centimeter just anterior lip of the cervix. Otherwise, cervix was firm and parametrium, left parametrium was thick, right parametrium was free. Just small ulcerative lesion, 1 centimeter.
Yes, and you had a LBC or a pap smear suggestive of
no before
invasive,
that before it was outside our hospital. It was diagnosed with adenocarcinoma.
Okay, actually, I have a doubt about the report of adenocarcinoma in situ. Yeah. You already have an ulcerative lesion at the anterior lip.
Small 1 centimeter ulceration, but after when yes. we did the surgery after seeing the patient 7 weeks after that, we found that the specimen there is no lesion. That may be the ulceration. That may be that due to the biopsy. Okay. I think so.
Okay. And the other thing that I wanted to know was the MRI report. Yeah. Did it show parametrial infiltration? Because what I could see from the MRI was that the uterus was pulled to one side. So clinically, it could have felt as a thickened parametrium, which was never involved. So it was not a stage 2B.
Yes.
It was probably a stage 1B.
Yes.
And that too maybe a 1B1.
Yes, yes.
Bhavna, let me make a comment here because the problem is that there was an invasive biopsy proven adenocarcinoma. And thereafter, yes. The next examination showed there is a small lesion. So whether there is a due to surgery or not, we don't know, number one. Number yes. two, to answer to your question, MRI said that MRI was done after the biopsy, that they could not see anything except a very suspicious, very small mass, maybe in the cervix. Even for that, they were not very sure. They make no comment about any involvement of parametria or any nodal involvement. So, as you said, as per radiologically, it was a very early stage tumor, but clinically, there was an invasive tumor at the beginning. Biopsy was done, but later on, during the clinical examination, they were finding that one side of the parametria was slightly thickened and another was free. That was their clinical findings. But radiologically, yes, you are correct. It is never to be in radiological. Radiologically, it was maybe 1B1.
Yeah.
Kamal bhai,
yes.
Actually what I want to mention that if we have any biopsy from outside, we have to reevaluate the case. And the area was raw. So we have to give 6 weeks to heal up the raw area to avoid granulation tissue. And after antibiotic coverage, re-evaluation of the case by cone biopsy, I think cone biopsy should be done before proceed other procedure. And on the other hand, MRI report shows no parametrial involvement. So it may be a very early case, and we could do a cone biopsy before going for radical hysterectomy.
Can I mention? Can I make a comment?
Yes,
I am Jannatul.
Yeah.
Actually, clinically, as Farhana Kalam has mentioned, that left parametrium is thick.
Yeah.
But Farhana didn't mention the details like any nodularity or shortening or fixity. And I think this, and she, another thing she mentioned that left parametrium, left fornix was tender. I think there may be coexistent PID, pelvic inflammatory disease, in this condition, and as biopsy has taken outside. So before doing examination under anesthesia, repeat UA, in this case, one course of antibiotic could be given in this patient. And if after 7 days UA done, then the finding could be that the left parametrium is not thick. So the stage could be, actually, it is down stage, that is 1B1. And what Rokeanorapa said, when in biopsy report, there is invasive squamous cell carcinoma, then there is very little chance of doing cone biopsy. When we do cone biopsy, when there is any suspicion regarding invasiveness, then we could suggest cone biopsy. I think in this case, there are two options: one, to give antibiotic, and then to repeat UA, and then we should say that this is a case of stage 1B1. So radical hysterectomy was performed, considering the other histopathology report, age, 44, adenocarcinoma. But it should be mentioned that the stage is 1B1, because in MRI there is no comment on parametrium, and it was absolutely normal. The parametrium was normal, size of the growth is small. So it is not to be. Clinically, diagnosis should be 1B1.
Yes,
Okay, thank you.
yeah, her first biopsy was done on 29th September, and second examination was done on 13th October. So we examined the patient after getting antibiotic, everything after 2 weeks. And during surgery, her parametrium was really thick, and it was really difficult to exercise. So, and another thing is, the Dr. Ruke Anwar, when it is diagnosed already, it is invasive adenocarcinoma. So, whether it is any necessity of the cone biopsy in this type of patient?
Actually, you can do cone biopsy because you can see either margin free or not. If it is microinvasive adenocarcinoma, it may be microinvasive, and biopsies mean sometime remove the lesion. We have seen many times different types of cases from outside biopsy, even invasive cases proved as non-invasive. Invasive squamous cell carcinoma become non-invasive or carcinoma in situ. Sometimes punch biopsy forceps removed the lesion. In case of very micro-invasive adenocarcinoma, I suggest to do a cone biopsy to see the status of the margin and to apex to see the end. With in addition to it, I also like to do an ECC, endocervical curettage, to confirm the diagnosis, nothing else, just to confirm diagnosis, and it will guide me to do a extrafacial hysterectomy or to do a radical hysterectomy.
The cervical curettage was done of this patient as first time when biopsy was taken.
Actually, when there are two reports in my hand, one is invasive squamous cell carcinoma or invasive carcinoma, and another is carcinoma in situ, I think it is better to consider the worst report and to manage the patient in that way. This is one thing. And in this case, I think review of the slides from both the old block, that is from the biopsy report, and from the new block, it can be done. And in many cases, this may happen. First diagnosis is invasive carcinoma, then the report come as carcinoma in situ. Okay, in that case, we can observe the patient. No need to give adjuvant therapy. We can just observe the patient. But regarding management, I think management was accurate. and patient got the actual
I
management.
appreciate your advice. It's okay, it's appropriate. And I want to know something about from our seniors who are here. AK? Oh, she has left.
Dr. Jannatul, your answer is we did it. We reviewed the both slide and final comment was that the first report was invasive carcinoma and the pathologist told that in first slide it was the invasive carcinoma and during surgery it is just the gross disease was removed, just it is the adenocarcinoma. We talked with our pathologist and he reviewed the both slides and gave
Yes,
his comment.
that means in first biopsy, the whole carcinomatous lesion was went away.
Abuna?
Yeah, I would just like to make a comment regarding the confusion in the two histologies that have been there. It is not uncommon for us also to encounter such problems. And the most common scenario where we encounter this problem is that the patient undergoes a pap smear or a liquid based cytology prior to a biopsy, and then a biopsy comes as something different, and the LBC is different. So, in such cases, we rely on the biopsy more than the pap smear. And in this particular patient, we would rely more on the final biopsy, final histopathology report that has come on after examining the entire specimen. So, I mean, that's the way we go about such situations. So, a biopsy any day is a better, tells us more or is more convincing than maybe just a pap smear, which could easily lead to confusion. The other thing that I wanted to know was that the histopathology report seems to be inadequate. There are a lot of other pathological parameters that we would like to look for deciding adjuvant treatment. So do we know about the stromal, like they have just given it's in situ, that's it. Okay, so that's all we have. Dr. Kamal, what would be your plan in this patient? Would you like to give any adjuvant treatment, adjuvant radiation?
Hello.
Kamal, you are not audible. Kamal, you are not audible.
So am I audible now?
Yes.
Hello.
Yes.
So
Yes,
I missed the question. Can you please repeat the question? I think I missed something.
Okay, Dr. Kamal, this patient, like I was just wanting to know what would your plan be in this patient, because the biopsy report only shows carcinoma in situ. They are not talking about stromal invasion. And then hence, of course, they cannot comment on the LVI once there is no stromal invasion. So in your center, would you want to treat this patient or not?
So what I want to do, as you mentioned, that here the problem is that initially when the biopsy was taken, they have taken the most of the tumor. So what we are seeing now is the remaining part where there is only foci of this carcinoma in situ, as you say. So to me, I will go back to my pathologist with both the slide and the whole specimen. And I want to discuss with him that, look, I understand that the majority was taken out along with the first specimen and you have only the remaining part, but I want him to go through the report, definite report about the parametria, because the parametria is the gray zone. They are finding it thick, but the MRI is not telling anything, because as we know, if that whatever we see is there is no stromal invasion, the parameter is free, the tumor is small, adeno, I will be happy to leave her without any adjuvant. But if we miss anything anywhere, I mean, in this total process, maybe we'll miss the chance of curing her by giving some adjuvant treatment. So, you know, in oncology, when we give treatment, we are safe. When we say we don't give treatment, we are taking a big risk. So before declaring that that patient is not a candidate for adjuvant treatment, I want to sit with my pathologist with the total scenario, not the piecemeal. That, look, I want to have a total picture. That tell me now, combining both the report, that is the biopsy and the current, what is your take on the tumor size, and what is your comment about the, make a specific comment on the thick parameter, which was feeling thick, and when the surgeon was doing the surgery, she was also feeling that it was not easy to dissect. So I want to have a clear-cut comment from him that there is no such involvement in this area. And if everything is free, like what we see now, probably I'm not going to give her any adjuvant treatment.
True, because I saw the whatever pathology was shown, there is no comment regarding inflammation also. So if the parametria was thickened, the posterior fornix was tender, at least some inflammation or something I would have expected on histopathology in the parametral region also, if not malignancy. So that is also not commented upon. So definitely, I think it is worth going back to the pathologist and asking them to review. But having said that, this is a very good case for discussion. It would get all of us scratching our minds regarding what to do additional. But had it been an invasive carcinoma, an adenocarcinoma, would your practice change? Because evidence really doesn't suggest much. But again, adenocarcinoma is, I would still take it with a pinch of salt, the histology, if it were an invasive adenocarcinoma.
Yeah, I agree with you, Bhavna. The problem is here that, say, it was me, let me now disclose. First patient came to me for chemoradiotherapy. Considering it as an adenocarcinoma, I was pushing for surgery because I was thinking that because the going back to the very old trial of the Landoni et al, the 15% additional survival with the surgery. So not being a surgeon, I am a believer of surgery like the Japanese for the adeno when it is possible. Even in a borderline situation, I am in favor of going for surgery and putting adjuvant treatment rather than going only chemoradiotherapy, because that adeno doesn't respond like squamous. So I am ready to give her adjuvant treatment if there is any single risk factor is present. I don't wait for 2. If it is squamous, I wait for 2. But if it is adeno, even one risk factor, I will go for adjuvant because it will give her an additional survival benefit. Because before we used to know it was a local control, but now the 10 years data is telling that the adjuvant radiotherapy is giving survival benefit also, OS and DFS both. So as you mentioned, as it is an adeno, I want to go aggressive. But if I don't have any information from the pathologist except this 1 centimeter tumor, probably even scratching my head, I will not do anything other than putting her on close observation.
True. I am so glad you said that you will use even one risk factor if it's an adeno, because that's what we do in our practice too. Because adenocarcinomas are notorious, and I would want to do everything possible to have a good outcome in a patient who is an early stage. Again, like you said, though I would be very much tempted in this patient also to give adjuvant radiation, I mean, the evidence or the information is not convincing enough.
I have a query. Yeah. I have talked several times with histopathologists about the parametrium, as because anything in parametrium, and she told that there is nothing in parametrium. You are sure? I have just missed that. And lastly, he gave the report that the parametrium is everything is free. I have a question. It was a stage 2B, early stage 2B in adenocarcinoma. In that case, what will be her treatment in adenocarcinoma, early stage 2B? It is plus minus 2B, yeah. In that case.
Yes.
Adenocarcinoma.
Kamal, would you like to answer that, or should I?
No, Bhavna, go ahead.
Okay. Dr. Shahana, in a 2B, we would like to go in for chemoradiation, radical chemoradiation, because there is some evidence which says that in adenocarcinomas, the results are equal if you are doing chemoradiation, not if you are doing radiation alone. But again, after completion of treatment, I would keep this patient under a close vigil, because if there is residual disease which is localized to the cervix, which is persisting there, maybe till the first follow-up, second follow-up around 3 months, I will not wait for 6 months. I would do an MRI and ask the gynae person to give an opinion regarding surgery. With adenocarcinomas, things can turn notorious. Dr. Kamal, what would you do?
I agree with you. Yeah, I agree with you. But answer to Shahana that yes, if it was not 2B, but if it was a borderline 1B2 or 2A1, I mean, where there is a debatable area of surgery and radiotherapy, I mean, where we always love to do some debate among the surgeons, not 2B, but it is 1B1 1 or 2A1, where there is both the option of surgery and radiotherapy, there probably I will try to make a combination of surgery followed by radiotherapy because of the advantage. But when it is a 2B, then probably, as Bhavna said, I will not go for surgery first. Here, the problem is the tumor was small. Yeah. So that was the tempting part. And MRI was clear about the parametria. That was the secret of pushing the patient for surgery. But if the MRI was telling that there is some involvement of the parametria, probably we will not go for surgery.
Dr. Kamal, I completely agree with you. And for the radiation oncology students, if we have them here, 1B, 2 and 2A1 in adenocarcinoma is an area where, contrary to what we do, we try and push these patients for surgery. Otherwise, usually it's the other way around. We always are debating with the gynae people to give these patients for chemo-RT. So this is one situation where we want the surgeons to operate if possible.
Is the big message here. The point of bringing this case here was not only because it is interesting, but for the juniors, that we need to really give the message what Bhavna said. This was the message I want to give to my juniors, that, you know, adenocarcinoma, then even it is area where we can give chemoradiotherapy, but we push for surgery in a borderline area because we know that surgery gives us additional benefit over chemoradiotherapy in adeno, and we have always the room for giving adjuvant and giving some additional benefit.
I have a question. Shall we go for, sometimes we get request for doing surgery after chemoradiation for this adenocarcinoma. Sometimes. In that case, what should we do?
Bhavna made it very clear. Would you like to repeat the thing, Bhavna?
Yeah.
Yes. What we do, Dr. Shahana, is that we generally repeat an MRI of the pelvis for these patients at 3 months.
At 3 months?
Yeah. Yes. Yeah. 3 months, they say usually there should be resolution of the disease on MRI. So if there is persistent disease on MRI in an adenocarcinoma of the cervix, I would definitely send this patient to the gynae for opinion regarding surgery. An adenocarcinoma, I'm saying, not for a squamous cell carcinoma. Again, if it's a small squamous which is confined to the cervix, I could think of repeat brachytherapy. But in an adenocarcinoma, if there is residual disease confined to the cervix, post chemo-RT after 3 months, I would seek a gynae opinion.
Yeah, here I want to supplement with Bhavna that here you see always we are talking about this histopathology. When it is adeno, we are taking a decision after 3 months. But if it was a squamous, we would not talk anything before 6 months. Because 6 months is the benchmark for squamous cervical cancer. Because we know many things may happen within 6 months' time. So to declare a patient that it is not totally resolved or something, we need to wait for at least 6 months when it is a squamous. But we take an early decision for adeno again because we know that surgery can give a benefit here. That's why if we have a room for surgery, we need to do it fast so that we don't allow the tumor to get chance to spread. So, you know, always in cervical cancer, even the percentage is very low. The story of adenocarcinoma is totally different from squamous regarding the preference of chemo-RT, seeing the response, post-chemoradiotherapy surgery, even the survival, everything is totally different. And still, I think it is not a very comfortable zone for us, the radiation oncologists, when we see adenocarcinoma. And even for the diagnostic dilemma, even it is endophytic growth, we are not sure whether it is a endometrial or squamous, the cervical. But still now we have some IHC, which is giving some clue. But still, I think sometimes we have some gray zone there where we really struggle to manage this type of patient.
Another thing that I would like to add for the students is that there can be 3 possibilities in this scenario. Like Dr. Kamal said, endometrium. Then there is endocervical adenocarcinomas. Again, they are the ones which are quite aggressive as compared to the ones that are the purely cervical cancer, the ectocervical adenocarcinomas. So whenever you have an adenocarcinoma, we usually go back and try and do an MRI if possible. If not, at least do an ultrasound to see the endometrial thickness.
So just my question, Bhavna, if somebody can afford a PET CT for this type of situation at the 3 months, would you prefer MRI or PET CT?
I would,
After
Dr. Kamal,
post-treatment,
any day
see the
for the
residual.
local disease, I would prefer an MRI. Because this
Yes.
patient, yes, but if it was an advanced patient, then things would have been different. Then that time the question of surgery would not be there if we were dealing with a stage 3 or so. But definitely MRI pelvis for assessing the local response.
Yeah, that is the message. Actually, to see the cervix, still the best modality is the MRI with contrast. I mean, nothing more than MRI with contrast for cervical cancer, local, identification and the parametrial invasion.
Yes.
Even PET is good for note, not for distance.
Yes, but there have been times when the MRI has also led to some confusion when they talk about gray zones and possible residual disease. So again, there we are in a fix. So in that particular situation, there will be a few situations like that. Then we prefer to get a PET maybe again after 3 months, that is 6 months.
I have a
that
question.
is
See
another
whether there
take.
is viable
When you
disease.
are doing
Yeah.
a MRI, you are doing it 3 months, but when you are having a doubtful area, so go back to the old formula of 6 months and then do a PET, because unless it is 6 months over, you don't declare that it is, that the story is over. I mean, when it is an adeno even, if you are not sure, then you need to wait up to 3 months or 6 months to
Yes.
finally declare it. So for the junior, there are a few oncology resident I can see. For them, I think it is a very important discussion that happened today. I mean, hardly you will listen in the class because class lecture is taken based on squamous and we just touch upon the adeno. But this much details, I think adeno discussion hardly happens. Thanks, Bhavna, for all the discussion.
Yeah, you're most welcome. But the other thing is, Dr. Kamal, this is basically based, I think, on our clinical experience more than what the evidence is. So I think that also is a take-home message, that the more number of patients you see and the older you grow, you perhaps become wiser in terms of treating your patients.
Yeah, and experience, the advantage is that we can borrow the ready experience of the seniors very
Yes.
early, then become knowledgeable.
I have a question. Yeah, Dr. Bhavana. Sometimes we get the patient, when patients, they come to us for follow-up after 8 weeks or after 10 weeks. In that case, we find that there is the vaginal discharge or there is some friable tissue in the cervix or vagina. As you tell that you will follow up the patients or do the MRI, whether it is decidual or not, for 6 months. And if it is in that case, what will you do?
Dr. Shana, at 8 weeks or 10 weeks, honestly, I will not. 10 weeks would be 3 months,
Yeah.
Yeah.
Sometimes you get there is vaginal discharge or there may be.
You could do a simple course of antibiotic, but honestly, I always prefer these examinations being done by a radiation oncologist post radiation treatment, to ascertain or to take a decision on these cases. I would not do a routine MRI for a patient who is having discharge. It could be infection. I would give a course of antibiotic and then again reassess.
Even after antibiotic, we get that there is some discharge or sometimes patients they complain of when the bleeds on task. In that cases, even after 3 months, in that case, what will you do?
Then in that case, you can, if the clinical examination, that sometimes we see when there is an endocervical growth, occasionally that kind of a picture can arise, or if there was intrauterine extension, in those cases you can do an MRI, but I will definitely not do a PET in this patient, because if it is inflammatory, again it is going to lead us in a wild goose chase. So I would prefer to do an MR if the patient is not responding to course of antibiotics.
Bhavna, I want to add here that the problem happens, what Shana is telling, that, unintentionally during brachytherapy, we do some injury to the vaginal wall. That is not for some injury and some radiation also. So it may persist few months.
Yeah.
Some watery discharges coming and patient is very difficult to manage. And we should not be tempted as a residual or recurrence. The magic number of 6 months should be there. So to declare, to give some chemo or to take a biopsy or to tempt for, do some PET CT, all these things. What is the target? Target to find that whether there is a residual. So we should not take any such crude, brutal decision before 6 months. I think that is a very hard point we should mention, because I have seen some of my colleagues that there are some watery discharge, point bleeding touch, and maybe they find some atypia and they started 3 cycles of adjuvant chemotherapy. It
No way.
happened.
No
But
way.
it should not be. I mean, the bottom line is we should not take any decision before 6 months.
And one thing again I would like to stress is please no no hard feelings for the gynecologist, and we do not underestimate your skill. But post radiation, I always prefer that the examination is done by the radiation oncologist, because there are radiation induced changes, like Dr. Kamal said. Yes, we've seen ulcers in the anterior vaginal wall with a particular kind of a ring applicator that we are using. Initially we were confused in a patient or two whether this is suddenly recurrence or something. So it is very important for a radiation oncologist to examine the patient, and I would strongly suggest that please ask the patient to be examined by the radiation oncologist as well. uh, the post radiation, for the radiation oncologist to decide whether further any imaging is required or not, or any adjuvant treatment is required. Starting adjuvant chemotherapy just on the basis of small suspected residual disease or suspected inflammation is absolutely wrong. Another message for the residents is, again by experience, a disease that has failed after radiation in the cervix locally will never ever respond to chemotherapy. So do not give chemotherapy for a local residual disease. Chemotherapy, the response to chemotherapy occurs in nodal disease, maybe in distant metastasis like lung or maybe liver, but a local residual post-irradiated cervix which has been treated radically never ever responds to chemotherapy.
Yeah, rather you have some opportunity to use some brachytherapy for not maybe curative, but for local. You can again try with some.
Yes, you can again
brachy,
try.
because it may respond to radiation, but it will never respond to chemo.
Yes, we have tried brachytherapy even at 3 months.
Yes.
We just contour that cervix area and give brachy.
So Shahana, I think we can.
Parveen Akhtar Banu madam is here. I want to request Dr. Parveen Akhtar Banu madam to make some comment. Or anybody, after Parveen Akhtar Banu madam, anybody from this floor, anybody can comment about these patients or anything. At first, I request Parveen Akhtar Banu madam to comment on this patient.
Bhavna, Dr. Banu is I think we can declare her that in Bangladesh, she is one of the pioneer for treating cervical cancer. Not only that, let me introduce her. If you take a statistics, I am sure there is no statistics. I think in Bangladesh, she has done the highest number of brachytherapy. And not only that, she is one of the lead contributor of this FNCA study group. And in all the cervical cancer study group, she has contributed the highest number of patients. So I am fortunate to be a member of her team. Appa, I would like to hear from you.
Okay, thank you, Dr. Kamal, Dr. Shahana, for asking me to say something. I am really sorry that I came late and I didn't hear the case presentation, but I just heard your discussion part about adenocarcinoma management and comments. Really very interesting and very, very important for the juniors. And especially Dr. Bhavna has addressed this issue that after brachytherapy, patient should be examined by radiation oncologist, treating oncologist. This is very important because post-radiation mucositis and toxicities, it is not well understood always by the gynecologist. So it is very important part. And another point is if there is any residual after treatment, then chemotherapy is not going to work. Dr. Bhavna has emphasized this point, and I totally agree. From my experience, I totally agree with this point. And taking biopsy within 3 months or 6 months also, I don't practice. I just want to wait and see what happens. And if at the end of 6 months, if there is something, something which I think that it is a residual recurrence, then I can take a advisory biopsy. And I had a question. What about brachytherapy, doing brachytherapy, re-brachytherapy, if there is residual after 6 months or even 3 months in adenocarcinoma after biopsy, if it is showed that it is there is residual or recurrence, then how you treat this patient with brachytherapy, how much dose you give, because you have given enough dose to your OAR. So how you treat this patient? I put this question to Dr. Bhavna.
Thank you, ma'am. It's been a pleasure to hear your comments. And it's again a very good question that you've put. In adenocarcinoma in brachytherapy, how I would look at is if it is a residual disease, which is persisting disease, the rationale for not doing brachy would be that since the disease has not responded to the initial 80 to 85 gray, the likelihood of the disease responding now, a residual disease, with the small amount of dose that you will be able to deliver is unlikely. So definitely surgery would be preferred. But if there is a small recurrence at the cervix, say maybe after 6 months or so, and if the patient is not for surgery for any reason, in an adenocarcinoma, definitely we can plan brachytherapy. And we then typically do image guided brachytherapy in these patients where we just prescribe the dose to the HRCTV to spare the OARs. We usually keep a record of our brachytherapy and the OAR doses for all our patients initially. We calculate the EQD2 and we generally go ahead with 7 gray into 2, or we've even done 9 into 2 for a few of our patients. So, but for squamous cell carcinoma, yes, if there is a local residual disease at cervix, even if the patient has a residual at 3 months, I would do brachytherapy. If it's a small residual, if she's responded and if it's a small residual disease. For an adeno, I'm not sure, ma'am, because honestly, the adenocarcinomas are very few. But as a comfort level, I would not be very comfortable doing a brachytherapy in an adenocarcinoma, which is persisting. Rest, I would even want comments from you with your experience and also from Dr. Kamal. What would you, because I think this is again a gray area. It would.
Yeah, that's right. Dr. Kamal, what is your opinion?
I mean, to be very honest, to get with adenocarcinoma recurrence, I have never treated with brachytherapy. I have treated with squamous.
Yeah.
And what I have done the combination of very focused boost of that area of brachy and EBRT. I mean, say BMAT of that area and also brachy combination. And I have tried that, and it was a good local control. It was something between curative and palliative. It was not a total curative, not even palliative, because I was convinced there was no distant metastasis. And end of the day, the result was quite good. And you will agree with me, madam, that cervical cancer is a funny disease that if you have a good control, sometimes with metastasis also patient have a very good life. I mean, long survival, patient live a good life. So to get the main secret is to get the local control. I think that's why I always chase with the primary I always a believer of 7:4 with 46. I don't compromise my brachy dose because I believe that I get one chance, one life. So I always chase with my brachy. And because my mentor, Dr. Very well, he treat 5 fraction.
5 into 5.
5 into
5.5 into 5.
Yeah, he is a believer of 5.5 into 5. And his concept is very simple, that push as much as with the brachy. And sometimes he used to use the central shielding. And my take is, even I don't do practice much, but a country like us, where we are doing conventional, I think the Japanese idea of central shielding is very helpful, because you see the lowest number of toxicities among Japanese, because they fundamentally they use central shielding, 3 centimeter. So if we practice central shielding, that may be a help for four-piece box technique like us with Cobalt or even Linac, that can reduce the toxicity of the rectal toxicity, and we can escalate the dose with brachy, because we are scared of brachy because of the rectal toxicity. But the moment we have the central shielding, we have a big room for chasing the dose of brachytherapy. So coming back to the recurrence, as Banua madam asked, that I have treated some squamous, but not adeno. And if unfortunately I have adeno, I would love to have a good surgeon colleague who can help me.
I know we would want to pass the buck on to the surgeon for an adenocarcinoma. Again, one point which I missed was that it also depends on the timing of recurrence. What is the interval that you can give the doses? You can escalate the doses. So we've even used small pelvic field. Just uh, confining our fields to the true pelvis, and for external, combined with brachy, like you said. So we've done that for patients who've had late recurrences.
Thank you, Bhavana, for excellent discussion. I like to add that I love to multidisciplinary management of these cases. So after radiation, I love to examine the patient, both in the department of radiotherapy, also in the gynecological oncology. The most important thing is experience.
Yes.
Experience, we know what is the inflammation, what is the radiation reaction. So we should not take any drastic decision before 6 months. So we need to give time to healing the radiation reaction and inflammation. So if any recurrence that is central come from after treating adenocarcinoma, if we have any facility to do chest CT or PET CT, if it is central and a small lesion, I love to do a surgical treatment, extrafacial hysterectomy. That may be really palliative surgery, just palliative radiation. So if it is a case of adenocarcinoma and recurrence in central position, I prefer surgery, and I like to follow up the patient in both the department, conjoint follow-up in radiotherapy department and also in gynae oncology department. But I don't know why our resident and also some of our radiation oncologists dislike parvaginal examination. They prefer imaging to detect recurrence and residual. So thank you very much for your.
I think, sorry for interrupting, but I think again a very important message for the residents. Nothing matches your finger examination by your finger in cervical cancer. I keep repeating this again and again for our residents also. Whenever you are going for planning, also if you've examined the patient before, please before planning again re-examine the patient. The person who is planning should re-examine the patient. No amount of fancy imaging is going to give you the amount of information that your local clinical examination is going to do. Ma'am, another thing that I would want to add is that we've seen a few patients where you feel that there is a recurrence, the cervix will be raw, and sometimes you feel there's some kind of discharge or something. But what we realized is that in diabetics generally these kind of changes are seen, which can easily be confused with local residual disease or a recurrence. So another thing that we generally do is we go back and we ask the history, and please check her blood sugar levels also. In uncontrolled diabetics, usually they can be local fungal infections, they can be local areas of raw cervix post radiation and post brachytherapy. So that is what I wanted to add.
Good point.
Thank you. Thank you very much. Yeah, sir. Thank you, Dr. Bhavana. We are very sorry that we engaged you for around 2 hours. This is Bangladesh time. I had to remind you. You thought that it was your Indian time, so I am very sorry.
No, not at all. I got confused a little.
Thank you very much. Sir, you please make a comment and end the session. Sir, please.
Yes, thank you very much. Very lively discussions took place. Both the cases were quite interesting. And for the second case, I should make a comment that during presentation of the case, we have missed many points which came afterwards. We discussed with pathologists and all these things. Some points came up afterwards during the time of discussion. If we could place this before, at the time of presenting the case, you could have added those things. Got my point?
Sir.
Yes, sir.
Otherwise, quite good. Thank you, Bhavna. You've taken lots of pains. Arvind also. Arvind remains silent all the time. Never comes forward.
Yeah, thank you
I
so
like
much.
to hear and learn.
Okay, thank you all very much. It's all quarter to 11.
Thank you very much. Thank you so much, everyone. And thank you, Dr. Shahana, Dr. Kamal, Dr. Mohammed, and everyone else. It's been such a pleasure for me to be associated with you that I almost feel at home now with the Bangladesh, the oncology group, the gynecology group. Thank you again.
I request you, it's invariably, I will request and invite you for our program.
It will be my pleasure anytime. I cannot refuse you, Dr. Shahana.
Thank you. Thank you. Very
So good of you. Okay. Bye bye, everybody.
Thank you.
Good night.
Good night.